G'day, my name's Chris Nixon, and I'm going to give you my take on the future of ICU education. Use the URL shown on the title slide to get further links and resources related to this talk. Now, we all know that the future is unpredictable, but we can try to anticipate and prepare for future change, or even better, act to create the future that we want. So the way that I've tried to tackle this is look at existing hard trends, measurable facts about transformations in a field, and to try and understand the present, because in many ways the future is already here, it just isn't evenly distributed yet. Let's start with the hard trends in education, which Simpson and colleagues in 2018 identified for medical education, but I think we can apply them more widely to the interprofessional ICU setting. So at the top, we've got outsourcing. So this means using pre-packaged resources as opposed to reinventing the wheel all the time. And we could get those from colleges, interprofessional bodies, online textbooks, or free open access medical education foam resources. There's the rise of learning analytics, so using multi-source information, big data to track learning progress. And technology is a big player, whether that be through the video and audio communication tools that have been so critical for remote learning, especially during the pandemic, more sophisticated learning management systems, or technology that's used in simulation and extended reality. There's also the concept of learner as consumer and co-designer. So as consumer, there's now a huge number of courses out there, and learners can pick and choose from these and develop their own micro-credentials. And as co-designer, they can create their own resources, either as foam or within education programs as part of project-based learning. And the last key trend, hard trend, is regulation and alignment. And that's important because regulators and accreditors are likely to continue to drill down on the link between education and patient care outcomes. And I think that means that there's going to be an even bigger focus in the future on interprofessional team-based approaches, because it's the collective competence of teams that really drives patient care outcomes, regardless of the individuals involved. So in response to these hard trends, Simpson and colleagues identified the following emerging educator roles. Diagnostic assessor, so that means using all that multi-source data to identify and close performance gaps in learners. They're going to be content curators because they have to select, sequence, and deliver outsourced content. Obviously, they'll have to be fluent in selecting and using different technologies appropriately to achieve all of this. And learners are going to need help or guides to using different resources and coaching to reach their performance targets. Clinician educators have always been role models for their learners, but it's going to be trickier to be an exemplar for future clinician roles because these are going to keep changing over time. And finally, whatever we do in education, we're going to need an up-to-date science-based approach to teaching, to program development, curriculum, and designing assessments. Now let's look at the hard trends in intensive care. So at the top, I've got the affordability crisis. And what this means is that healthcare models will need to evolve and become more efficient. And that's because to overcome existing and future healthcare inequities in the face of increased future demand and cost, we're going to need to work very differently. Part of this will be driven by changing healthcare needs, so aging populations, patients with more complex comorbidities, and of course the ability to meet external crises episodically like pandemics, environmental disasters, and even war. Technology is a big player as well, whether that be the rise of telemedicine, whether that be more advanced electronic health records and decision support systems, as well as all the devices for monitoring, interventions and organ supports that we'll be using in ICU. Changes in the workforce will be critical. Now, we already know that stress and burnout and well-being are obviously critical and need to be continually addressed. But we'll have a more diverse workforce, and there'll be other demographic changes like an ageing workforce as well. And in particular, over the next 10 to 20 years, there's likely to be the intensivist retirement time bomb will go off. We've also got to address issues with professionalism like bullying and other systemic biases that are built into our systems. Underlying all of this, intensive care is going to need to be adaptable. So both intensive care units, they need to be able to modify according to patient needs and society's needs, as do the individuals working in them. So what will future ICU teams look like? Well, intensivists are not going to go out of a job because they have a generalist skill set and a cognitive skill set that enables them to do decision making and communicate effectively around uncertain and rapidly evolving situations. But training more and more specialist doctors isn't going to be the long-term solution to the affordability crisis. So we're going to need expanded interprofessional teams. And it's lucky that you don't need to be a doctor to be highly skilled and to look after patients. So these new teams that are likely to be led by intensivists will have additional roles, things like physician assistant roles, more specialised nurses, device technicians, as well as expansion of allied health services. So an interprofessional approach is critical for the future. So given all these changes, how do we respond to rise to their challenge? Well, at the macro level, funding is going to be critical. So back in 2010, it was estimated that only 2% of healthcare funding globally went into education and training, which seems so low for a labour-intensive, talent-driven industry. And we know from the pandemic that even if you have enough ventilators and beds, you still need skilled staff to look after patients. So we need to overcome this funding neglect. I've already mentioned that healthcare models and workforce changes will take place. And related to that, it's going to be essential to coordinate the training pipeline effectively. Currently, we have a gap between training bodies and workforce planning. We need a unified vision to integrate who gets taught what, where, and to who, and to integrate undergraduate, postgraduate, and continuing medical education. But that's all a bit above my pay grade, to be honest. Other things that we can do to help create the future is create clinician educators. And this is what we've been involved in through the Clinician Educator Incubator program that's supported by ACCCN, ANZICS, ANZIPI, and CICM. And the idea is to continue to build an interprofessional community that seeks to develop the skills required of educators for the future. But there's also a gap in education research and scholarship. So we need to continue to support this going forward. And I know that the Intensive Care Foundation is looking at diversifying how they supply their grants to support this. But wouldn't it be great if we could encourage CICM trainees to have appropriate education projects as their formal projects, and also for all our professional body journals to have dedicated education sections so that we can all learn and stay up to date with this critical topic. There is, of course, going to need to be changes to the curriculum and how we deliver training. So curriculum always need to undergo renewal to continue to prepare professionals for the future. But I'd see that topics like telemedicine, leadership, professionalism, interprofessionalism, and well-being are going to need to be integrated into everything that we teach. Training will also become more explicitly competency-based and will be time variable. So this means that trainees won't train for a fixed period necessarily, but will train for different lengths of time, whatever's required for individuals to develop the competencies they need to be trusted to look after patients. And the way to do this is most likely going to be through programmatic assessment, which is using a huge number of data points from multiple sources, back to big data and learning analytics, that we can use to track progress help coach learners, and ultimately allow high-stakes decisions about their training to be made fairly and with confidence. Furthermore, we're all going to have to learn how to learn. So we're going to have to teach trainees how to learn, and also ourselves, so that we continue to undergo lifelong learning and keep pace with the rate of change in ICU and be adaptable to whatever the future may bring. Change is coming, and it is inevitable. We need to future-proof ICU education so that we can get the best patient outcomes, whatever the future may bring. Thank you very much.